which address some sort of patient safety issues here. I have no disclosure, but I'm working on it. Introduction. Since the introduction of the pedicle screw fixation by Roy Camille, fixing pedicle with a plate through the screw, with a screw, that was made a significant paradigm shift in spine instrumentation. However, this is not associated with a little risk. There are some major complications can happen from that due to injury of vascular structure, which is rarely now, and sometimes injury to the nerve root and the spinal cord. In this study, where there's a survey analysis of more than 600 patients by ACES in 1990, he found that there is a 5% incidence of unrecognized screw displacement. And the author concluded that the pedicle screw is still associated with significant intraoperative and postoperative morbidity. And they suggested also that repeat surgery can be associated with a great number of complications. So if you go to most of the spine meetings, half of the exhibition showing screws, half of them showing you tools, how to prevent having complication from these screws. And there is a lot of long list of how to do it. There's a shift from free hands to robotic, the use of intraoperative image guidance through a preoperative obtained CT scan, intraoperative 3D fluoro, or intraoperative CT scan as well as in our series. There are some other tools that might improve the safety. The easy one is technical. You do wide laminectomy. You see the pedicle and put your screws. Other like using the PediGuard, EMG, and other intraosseous ultrasound and endoscopy being done. However, once these are really provide you a very safe path for your screws. But once your screws in, very unlikely your screws will be deviated due to insertion, but it can happen. So to do that, you can do simply a 2D fluoroscopy, which everybody is doing that, but sometimes it's not very good in some patients, obese or intraocular or high thoracic. So you need to do some fluoroscopy, like a arm, a quick run, or a CT scan to make sure that your screws in adequate place. So in our hospital, we managed to get an intraoperative CT scan, and so we have to convince ourselves and the administration that's worth having this expensive device. And so we did a small study, which is prospective observational study, just to check the accuracy of the device. And we compared the screws inserted with the intraoperative CT scan to the conventional that everybody is doing with a 2D fluoro. We get our approval for the study, and we looked at the lumbar more because of there's many variation in numbers between the thoracic spine in both groups. Everybody had the straightforward clinical assessment and radiological studies, and we did not include children. And at that time, we did not have the MIS kit for the intraoperative CT scan, so we did not include them, as well as extra lumbar fixation. How we did assessment for our pedicle screw, we did the very famous Canadian study done in the 90s by Grisman and Robin. This is a very old study, but it's still now everybody's using it. And basically, they have done CT scan to see the deviation of the pedicle through the screw through the pedicle. If it's in the center, most likely this is A. If it's deviated a little bit to one side, but it's less than 2 millimeter shift, this is a B. And then you go on to C and D and E, which is, in these cases, there is a breach of the pedicle cortex. We had two independent evaluators to assess the violation and between the two groups. Of course, we studied the intraoperative CT scan obtained by the first group, and all the patients who had postoperative CT scan. In the control group, they had evaluation. And we correlated the CT scan for both groups. So this is just a quick example showing how this is a CT scan done from the intraoperative machine, so it's very, very accurate. You can see all the details, and this is the navigation used for this group. And this is for the fluoroscopy. All of them, they have CT scan, as you can see the quality here. And we usually do X-rays, and also CT scan can be done. And we can always use the software to measure the pedicle in the screw in the pedicle. We did the analysis, and although this is a short study, we have a short follow-up, but we have 15 in the IOCT group versus 42 in the conventional group. The age and sex were not much different. And again, most of them were degenerative, some of them trauma and one infection. And if you look at the screw accuracy in this group, in your left side, you will see all blue, which is very good, A and B. You know, on most of the literature, when they assess the accuracy and use this accuracy paper, they fuse A and B together. So this is less than 2 millimeter deviation, which is very accurate. We have 1 minute, please. Okay, in the other group, there is some orange color, which is deviation. I'm not going to go through this number here, but it's very clearly, if you have A and B, so the first group has almost, I can say, 100% good study. When you look at the other group, there is C and D, which is, most of us will have this, and if you are doing navigation sometime. Although the number is quite less here. So post-operative clinical assessment, we're working on some of the function of those patients, but there is no much really different apart from the slightly longer intraoperative time as expected. In the reoperation in group, we had 2 patients reoperated. This is an example of reoperation of this patient. You can see the right L4 pedicle deviated medially. In the CT scan, it's very obvious, and he has a D, grade D. He required reoperation and putting a cage as well. Literature review, you will see thousands of literature. If you trim it down to meta-analysis, you're going to have 15. The latest one by Audi showed there is a significant number between the 2D fluoro or freehand versus navigated one. But the problem here is reoperation. If you consider your reoperation rate is high, then you might really need some help to do that. It's not very costly if you consider the reoperation day expenses that you're paying for your reoperation. And
Professor, can you conclude, please?
Yeah, exactly. I'm concluding here that this is an expensive thing that you will get, but you are putting your money on the reoperation of those patients. I think the outcome eventually might be better with the use of intraoperative navigation in your cases. Thank you.